To our weekly echo session hosted by the Gastro Foundation of Sub-Saharan Africa in conjunction with Project Echo. My name is Chris Cassanides, and I'm very happy to welcome you all here this afternoon. Today we'll focus on patient blood management, and particularly the GI evaluation in the management of iron deficiency in Sub-Saharan Africa. And I'm very happy to say that this concept, which began approximately 18 months ago with discussions between myself and Dr. Wayne Simmonds, our presenter this afternoon, a gastroenterologist at the Universitas Hospital in the University of Free State here in South Africa, have eventually and finally been submitted to the South African Medical Journal for publication. And it's a very important document because it clears up and identifies many areas which have been quite contentious over the last years. I also want to congratulate Wayne because it's been a kind of a difficult, not a difficult, but a project which really needed a lot of fortitude, and you needed to just wade through all the issues month by month, week by week. Finally, the document is done, and we look forward to the publication. So over to you, Wayne, and thank you very much again for all your efforts. Will you unmute?
So, greetings to everyone. I'm Wayne Simmonds. Thank you very much, Prof. Cassanides, for the kind introduction. And I must say, before starting, to just at the outset say thank you for the call one very busy afternoon doing endoscopy to take this challenge on, and I appreciate the opportunity. It has been a journey indeed, as you've described, and but it has been a fruitful one, I think, and one that has taught me a lot in terms of constructing such a document. So I'm really appreciative. Thanks again. So the idea of this afternoon will be really a prelude to the document. Obviously, we look forward to it in print. And it is basically the guidelines, the culmination of a lot of work by a number of people looking at this very important topic of iron deficiency and its evaluation and management in our setting in Sub-Saharan Africa. It all started in the mid-2021, early 2021, where I had a very refreshing talk to give at the start out of the ECHO meetings for me, where I gave a talk on, the approach to iron deficiency in an elderly patient with obscure GIT bleeding. And that sort of stemmed the whole discussion around, can't we expand on this and make it, use it to build on the guidelines, which were a more formal thing in the setting of Sub-Saharan Africa. So that's where it all started for me. And then we looked into the details of it, and we just cannot, afford not to emphasize the background of this very important element called iron and how it contributes to anemia. The latest figures from the WHO, these figures we all know, a third of the world's population is anemic, 40% of them being children, young children, pregnant women, 37%, and women of childbearing age, 30%. We know that the bulk of these patients that are anemic are nutritional, and then the bulk of those is iron deficiency. What we do also know is that gastrointestinal blood loss or malabsorption is the main cause for this. And in such a case, the evaluation of that patient will end up involving a referral to a gastroenterologist. And this way it came about that we don't have guidelines in South Africa for these gastroenterologists and for the practitioners dealing with these patients, and we set off to address this. So just an emphasis on the burden of anemia from the Global of Disease study in 2019. I'm not going to dwell too much on that. This tied in nicely with the discussions about patient blood management in South Africa, and we know the three pillars of patient blood management that it's based off, given in perioperative management of patients. But this evidence-based bundle of care aiming to optimize patient outcomes, was part of the drive and part of the motivation to continue with these guidelines and formalize them. These principles focus on the detection, identification, and management of the underlying cause of the anemia, and then iron deficiency is a bulk of these efforts. They regulate the use of blood transfusion, which then indirectly implies that, if you manage the cause, that helps to rationalize use of blood transfusion, and the evaluation and care of the patients, and then treatment of these underlying causes, which then the guideline focuses on iron deficiency. To extend it, we in Sub-Saharan Africa have a high incidence of anemia, frequent shortage of blood products, as we know currently, with a small donor population. Just recently, the blood bank declared that there were times where during school holidays, their main populations being the universities, would all go home for the holidays, and so there's a small donor population. Healthcare systems in Sub-Saharan Africa under financial strain, and this very interesting disparity between public and private sector. I've looked at the document by the colleagues from the Blood Service, Karen van der Berg, and very interestingly looking at public sector use of blood transfusion and then private sector use of blood transfusion, where one can easily see the skew in transfusions between 2014 and 2019, especially this belly-shaped female curve in the public sector. There was a quip recently about, this looks like a pregnant lady. And it's the reality of the situation with, patients, older patients getting blood transfusion easier, it seems, in the private sector. But this disparity of difference then serviced by the same blood service. So the PBM challenge, is to rationalize an equitable use of blood products, and iron deficiency ties into this quite nicely. So how did we go about it? The initial draft of the sections, the things we were going to talk about were discussed initially by Prof. Cassanides, Prof. Watermeyer, Prof. Seshedi, as he's on the call as we speak, and then much later, Professor Noel from the University of the Free State here. These were then taken, during the SAGES meeting and SAGES Guidelines Committee to review them and refine them. And give comments about them. And at that stage, there were just really these sections and areas that we thought were important with regards to the management of iron deficiency and the evaluation of iron deficiency in South Africa. These sections were general recommendations in practice: Helicobacter pylori, celiac disease, suspected small bowel bleeding, or the old term obscure GIT bleeding, inflammatory bowel disease, importantly, and then later preoperative care, which ties nicely in with the PBM efforts. The objectives were to aid clinicians in the evaluation of gastrointestinal loss, iron malabsorption, and interestingly, as in the setting of IBD, where there's a combination of these. The idea was to improve clinical outcomes for patients with GI losses, causes of iron deficiency, and then to provide a current evidence-based, context, Sub-Saharan specific-based blood management guidelines to be used, or to contribute to these blood management guidelines to be used in the management and evaluation of iron deficiency. And then ultimately to conserve resources by ensuring the rational usage of blood products and blood by optimizing the management of iron deficiency in the setting. We later then took these statements and this document, which was in these sections, to a meeting which was a working group in the Cape in February 2022. And those primary authors were all present, and we collected a group of 21 members in the end, which held a roundtable discussion in Cape Town, and that was a very interesting meeting, where we reviewed the draft statements to remove any ambiguity, ensure clarity, and optimize these concepts that we wanted to put forward in the guidelines. What followed then was, two different Delphi processes, 2 rounds of Delphi consensus statement assessments or surveys that went through these 21 members. The agreed to instrument was then used to guide us in this guideline setting up and processing. And these, at each step of these, the Delphi process, each statement was discussed and agreed upon. Just interestingly, we always, when setting up guidelines, want to have, a broad inclusion of the partakers of the guideline setup. And we did seek advice from patients. There were some of the practitioners that were involved in the group, the expert group, that were patients themselves. But the patients, the solitary patients, the nursing, there was a nursing staff and a representative, a senior representative from the blood service. But, on looking at the concepts and the statements, they felt that was too technical for them to partake, and they opted out of the process. This was a challenge with the SMJ submission, but, we had to make it very clear, this technical nature of the guidelines. Each statement then had to be graded according to its evidence, and this was done, and this took a lot of time, but I think we are at a state now where we could safely grade each statement according to evidence, and this is well referenced in the final document, and this is graded according to the Australian National Health and Medical Research Council, and I've stipulated how we graded it there. So A, with body of evidence that can be trusted to guide practice properly. So B, the same setting with most situations. C, body of evidence that gives some support that care should be taken in its application to the patient. And then D, where there's weak evidence for the concept. And we use this to grade. So there were two things: the consensus statements and the strength of the consensus statement based on the 21 members. And then afterwards, this grading of each statement based on the body of evidence available for those statements or where they were drafted from. Ultimately, we had to get a global or inclusive approach, and we eventually evolved from calling it South Africa to call it Sub-Saharan Africa, and we included colleagues from Ghana, Kenya, and Nairobi, and then Zimbabwe. We're very thankful for the inclusion. And then, as I've listed there, we see all the colleagues from South Africa, which was very well represented, and each academic center has been included, as well as outside of the public academic sphere. We've had a good inclusion of people in South Africa. So we're very thankful, and I express my great appreciation to all the contributors and that contributed to the document. It's taken time, and I trust that all their efforts will come to fruition in achieving the objectives of the document. So each person got an email for each of these two Delphi rounds, and they could literally just click on the email, and up would pop the consensus statement iteration. And then you would literally read through the statement, decide if you strongly disagree, neutral, agree, or strongly agree. And then there was an opportunity to give comment on each statement, which was very valuable in the setup of these. This is an example of what we would then receive for each statement. There were a total of 46 statements, of which we didn't reach consensus on one, and the other was included, was a redundant statement. So ultimately, there were 44 statements. We would get the figures then, the global figures from the 21 members. And we saw consensus where we had a more than 80% consensus for each statement. And we've listed the consensus then under each of the statements. Statement one had reached 100% consensus, with all members then either agreeing or strongly agreeing. And as we see here from one of the contributors, there's very valuable information. Often there would be a reference that really served as a valuable tool for us. As we've said already, the SMJ submission has been done. The first submission was in December 22, and that was returned in the first part of the year, where there was a lot of suggestions and clarifications that were sought about the document, a lot of smooth streamlining that had to be done. This has taken time again to look at each statement and make sure that they're in line with the guidelines, the agreed document, and the grading. And I'm glad to say that we've finally done, and this has now been submitted, and we await the final publication of the document. So to give just a look into it, so when we look at the general recommendations in practice, the statements that we have, are the ones relating to the general idea around the management of iron deficiency and its definitions and how we view it. And the first one says, iron deficiency we saw as a serum ferritin of a level below 30 nanograms per milliliter. That indicates a diagnosis of iron deficiency. So that was a strong consensus there. We then stated that the investigation should be considered in all patients with iron deficiency, regardless of the severity of the deficiency or status of the anemia. So we know that iron deficiency or anemia is but the last stage of iron deficiency, and hence, even in the title of the document, we've evolved to call it iron deficiency and not iron deficiency anemia, which we felt was a limiting statement. So the screening for hematuria and other potential sources of blood loss in patients with iron deficiency was important, so that we thought that this should be undertaken in all patients with iron deficiency. And then for cases where non-GI causes of iron deficiency have been excluded, the decision to perform either an upper endoscopy and then, if nothing was found, a lower endoscopy or bidirectional endoscopy from the get-go should be made based on the clinical picture and scenario of the patient. In the premenopausal women, the appreciation was given for menorrhagia and its important role that it plays in iron deficiency. And upper endoscopy and administration of iron replacement therapy were recommended. And if these upper endoscopy findings, or if the patient was not responding to the iron therapy, or a significant history of colorectal malignancy, lower endoscopy was recommended in them. The role of CT colonography was discussed. The idea there was that it was an alternative if colonoscopy was contraindicated in any way. Sigmoidoscopy may provide a diagnosis in certain circumstances, but most contributors felt complete evaluation of the lower gastrointestinal tract should be performed. Do not ignore the rectal examination, as your initial evaluation. Obviously, suspicious findings there, motivate thymus endoscopy when colonoscopy services are limited, especially. We discussed fecal occult blood testing. Many patients are coming in with these results of the FOBT being positive. Important to note that this is a screening test for colorectal cancer, and is seldom of benefit in the investigation of iron deficiency, and it shouldn't be used in this setting of iron deficiency workup, actually. In patients with iron deficiency, those that are intolerant or non-responsive to oral iron is common, and we recommended IV iron and intravenous iron in those cases. And then patients undergoing gastrectomy or bariatric surgery, the advice there is to monitor them and treat them accordingly, with the majority of these patients needing oral iron after gastrectomy or iron replacement after gastrectomy, where oral iron was not recommended and the administration of intravenous iron was preferable. We skip over to Helicobacter pylori. So in patients with unexplained iron deficiency, we recommended the testing for Helicobacter pylori using either the rapid urease test or histopathology where this was not available. Non-invasive tests where for some reason, the endoscopy findings where, we did not prove Helicobacter pylori during the endoscopy. And then administration of eradication therapy was paramount, just keeping in mind that the side effect profile with the co-administration mandates that one should consider giving the iron replacement therapy following the eradication of Helicobacter pylori. And then importantly, something that was discussed at length was confirming Helicobacter pylori infection or eradication. The initial thinking was that the symptomatic relief in the patient would suffice, but there's sufficient evidence to show that, one has to confirm after 4 to 6 weeks of eradication that you have indeed eradicated H. pylori, and the suggested test in the guideline is this non-invasive stool antigen test. We talked about celiac disease, and we have guidelines for that. We recommend performing evaluations for celiac disease in all patients with unexplained or recurrent iron deficiency. And the guidance here is that you should do initial serologic screening for these patients, and that should then be followed by small bowel biopsies in the seropositive patients, rather than routine small bowel biopsies in all patients with iron deficiency. Those patients with iron deficiency confirmed to have celiac disease should be managed accordingly with strict gluten-free diet and their iron replacement therapy. And then importantly, the presence of celiac disease should never preclude further investigations in males and postmenopausal females and in patients with history or family history of gastrointestinal malignancy. So those patients should continue to have their relevant screenings and cautions. Suspected small bowel bleeding, so the old obscure GIT bleeding. So in patients with normal upper and lower endoscopy, it was clear to us that an initial trial of iron replacement, preferably intravenous with close follow-up, is recommended over the routine use of capsule endoscopy. And then during this evaluation of suspected small bowel bleeding, if the endoscopist felt that there was doubt about the initial endoscopy, we should embark on relook upper and lower endoscopy. And then if further endoscopy was then required, or if those proved to be normal, this patient would then get the small bowel capsule endoscopy, followed by a directed small bowel endoscopy to address whatever was found on the capsule. So the small bowel investigation using the capsule endoscopy was then considered to identify obscure cause of iron deficiency in patients with normal upper and lower endoscopy. In some settings, the capsule endoscopy is not available, and then CT scanning or MRI enterography, is a reasonable alternative. In those patients with overt obscure GIT bleeding, preoperative red cell scintigraphy or CT angiography, or in some cases, intraoperative enteroscopy through a small bowel enterotomy was recommended. And this is the surgical patient where bleeding was obscure but overt. The intravenous administration of iron with close follow-up is recommended in these patients where, despite investigations, they remain iron deficient. And I think this is an important thing to remember, that you can still replace the iron and observe these patients closely. In replacing intravenously, one point is that you rule out malabsorption as a cause for this suspected small bowel bleeding. So I think that's handy, and I think it should be done. And these patients followed closely following that. Inflammatory bowel disease, very importantly. So all patients with inflammatory bowel disease should be assessed for the presence of anemia and iron deficiency, a very important manifestation or complication or part of the disease in inflammatory bowel disease. So they should all be screened at initial diagnosis and then should undergo long-term monitoring for the condition. The guidelines went about the laboratory screening of iron deficiency in these patients, keeping in mind their inflammatory state, and then goes into detail about how should one do this using the different tools that we have to our use, to our dispense in the evaluation of these patients. The information about transferrin saturation, together with the CRP, and then other tools like your soluble transferrin receptor and your reticulocyte hemoglobin content. These are discussed quite clearly in the guidelines. In patients with inflammatory bowel disease and iron deficiency, so the degree of active inflammation should be determined always, and that should be used to weigh, the risk of iron deficiency and the kind of iron deficiency and the level of iron deficiency that these patients are having, and the gauging of this inflammation. There's a number of ways set out in number 28, which shows us how to do this. For patients who are in remission, so serum ferritin and transferrin saturation levels should be performed every 6 to 12 months. And in patients with active disease, at least every 3 months, and this was 100% consensus. The absence of clinical or biochemical or endoscopic evidence of inflammation, in that absence, iron deficiency is considered likely if the serum ferritin is less than 30, similar to the patients without inflammatory bowel disease. However, in the presence of inflammation, we suggest a ferritin level of 100 as the cutoff. And then, further iron stores may still be inadequate in higher serum ferritin levels, especially if the transferrin saturation is low, that being less than 20%. The goals for treatment in iron deficiency and inflammatory bowel disease is to normalize the hemoglobin, serum ferritin and saturation, transferrin saturation levels, and to replace the stores. And then to avoid the need for blood transfusion, which can be counterproductive in these patients, and ultimately to improve quality of life. Patients with quiescent disease and with the HB of greater than 10 grams per deciliter, so you can consider oral iron in these patients as first-line therapy, but only once you establish that the patient is tolerating the oral iron. Patients with active iron deficiency or with iron deficiency and active inflammatory bowel disease should be treated with intravenous formulations if the hemoglobin is less than 10 grams per deciliter, or if there's an intolerance or inadequate response to the oral iron, or in the presence of significant inflammation, which we know hampers the uptake of oral iron or the absorption of iron. If the route of oral iron is to be undertaken, no more than 100 milligrams of elemental iron per day is recommended in these patients, and then the response should be assessed in all patients 4 to 8 weeks after the initiation of iron replacement therapy. We expect that the hemoglobin level should increase by at least 2 grams per deciliter from the baseline. If this target is not reached with oral replacement, intravenous iron replacement should be considered, and thereafter the hemoglobin level should be measured every 4 weeks until this target is achieved. Following an intravenous infusion of iron replacement therapy, you have to measure your iron stores, but not for at least 4 weeks after the infusion to avoid that initial phase and that flux of iron, the iron infusion. And it's recommended that the replacement therapy be repeated once the serum ferritin in that patient falls again below 100 nanograms per milliliter, or when the hemoglobin falls below the WHO cutoffs of 12 and 13 in women and men, respectively. Following the successful treatment in these patients, how long should we monitor them? So 3 monthly until you've normalized, and then 6 to 12 monthly are satisfactory in the treated and stable patients. Moving on to the preoperative care, I think importantly here that patients with preoperative iron deficiency should be investigated using a full blood count, serum ferritin, transferrin saturation, and a CRP to exclude inflammation before all major surgical procedures, especially those where you anticipate a loss of greater than 400 moles. Patients who are identified then having preoperative iron deficiency, if possible, the elective surgery should be postponed until the hemoglobin has been optimized. And it's recommended that the preoperative hemoglobin target of 13 for non-urgent surgery in males and females should be achieved. It's recommended that the preoperative patients with iron deficiency without inflammation and in whom surgery is scheduled longer than 8 weeks should be treated with oral iron. And then patients who need a speedier increase in their hemoglobin undergoing oral iron replacement therapy, that they should be, those on oral iron should be reviewed 4 weeks after treatment to assess the response and change to intravenous iron where necessary. In the preoperative period, we know that intravenous iron is safe for these patients and effective. And in patients whose surgery is scheduled less than 8 weeks, and then those, or those that are then non-responsive to oral iron, intravenous iron should be used in them. That's statement 44. One of the recommendations from the SMJ was that, we give guidance as to the evaluation of these patients, but in the sub-Saharan setting, it would be not correct or inadequate not to give good guidance with regards to the replacement of the iron in these patients that we would find to be iron deficient with gastrointestinal cause. And so I'm very thankful to the group, the primary authors, but specifically to Professor Vernon Lowe, who helped us greatly, with regards to looking at these principles. And at the end of this document, following the guidelines, is very valuable guidance as to how we should look and manage patients with oral iron, with good, well-evidenced suggestions there. Intravenous iron, the role of blood transfusion and how we should use iron judiciously or more frequently to avoid blood transfusion, how we should monitor iron replacement therapy, and shortly a short statement about the safety of iron therapy versus blood transfusion in the setting of iron deficiency and anemia. And the last part of the document looks at the implementation of the document, and we aim this at individual practitioners, specifically people working with people who have iron deficiency, which then is, a large percentage of patients that we see, and then patients who are evaluating these patients. And the center of it was gastroenterologists and anyone who is undertaking these measures to investigate these patients. And these measures can be implemented in healthcare institutions, department at all regional, district, provincial, or national levels. I think it's important that we will continue to monitor these guidelines and monitor them for adherence and look at the assessment or look at the effect on blood product utilization. I think that's something looking forward where these guidelines are instituted, that we can minimize blood product utilization in the setting of iron deficiency especially. And then, of course, periodic review and updating of the guidelines. Things change with time. And then integration of these guidelines into the relevant patient blood management protocols, where this stemmed from or which motivated a lot of this in the beginning. And we recommended this to promote this optimal evaluation and treatment of these patients with iron deficiency. Again, to emphasize this idea that iron deficiency there's a large spectrum of disease, when one talks about iron deficiency, and to limit this to iron deficiency anemia would be a shortcoming, and hence we set this guideline to aid patients regardless of the presence of anemia. That's just a short prelude. I think the guidelines and the further discussion and the motivation and the evidence for most of these guidelines, according to the agreed to and the grading of them, are clearly in the document and referenced well there. And again, thank you for your attention. I look forward to questions about it, and we look forward to the document in print. Thank you very much.
Thanks very much, Wayne. Excellent overview. So the discussion is, the presentation is open for discussion. I'd just like to make it a very important point, and you did make it, Wayne, is that the approach is through iron deficiency and not anemia. So the first, it behoves us, even though the gastrointestinal tract is a very common cause of iron deficiency, either through GI bleeding or malabsorption, it behoves one, firstly, to interpret your iron studies very carefully and establish that the patient is indeed iron deficient. And then turn to your full blood count, not only to look if this is associated with an anemia or not, but to look at the other parameters, the white cell count, and also the platelet count and the differential and the retic count, to make sure you're not missing a hematological cause for the iron deficiency. And then check your urine, not only for blood loss, but also for hemoglobin, to make sure you don't miss the very rare condition of paroxysmal nocturnal hemoglobinuria. So the point I'm making is that it's very important to make sure you don't have a hematological cause for your iron deficiency, which can be simply excluded on a full blood count and a urine examination. And we did make the point that stool for alcohol blood is probably not going to help you. Your urine probably is going to help you more than doing a stool for alcohol blood. And then once you've cleared up those, then you can start looking at your demographic and whether you're going to investigate the gastrointestinal tract. So I'd like to really emphasize that, because it'll help you when you get stuck later and you're not finding the cause, and then you go back to your full blood count, or you go back to, and you find, oh my goodness, this is a hematological cause, and in fact, maybe a bone marrow would have been more appropriate before endoscopy. So very important to approach this step by step and very carefully before proceeding to endoscopy. So there are some questions. There's a question about allergies to the intravenous anaphylactic reactions to the intravenous iron supplements that we're using now. How common are they, and should we be concerned about them?
Yeah, I think we've discussed this at length, and I think Professor Vernon Lowe is not with us today, but he was very clear that I think while we do see anaphylactic reactions from time to time, they are not common with the intravenous formulations, especially with the newer intravenous formulations that we see, which are given much quicker. Cosmofer and Monofer, etc., can be given very quickly without significant anaphylactic reaction. So I think while I don't have a figure with me now specifically, or an exact figure, but they're definitely not as frequent as we initially thought, and as we would see with the older formulations like Venofer, for example.
When should we use iron-rich foods?
So the iron-rich foods, we haven't really dealt with diet in this presentation, but I think to look at iron deficiency and look at the patient's diet is of course the first step. I think nutritional deficiency should always be addressed in all patients with iron deficiency, and we should look at iron-rich foods in all patients. I think that's not for any debate. I think if a patient admits to a poor diet, that should be addressed. And there are various, guides and suggestions as to what foods patients should consume. I think in this setting, the guidelines, we limited the guidelines to the iron replacement, the medical iron replacement that could be scripted. But certainly, there is a mention of addressing the dietary deficiencies in patients where found.
And then the use of hepcidin antagonists in the treatment of iron deficiency anemia. I mean, I'm aware there are both hepcidin agonists and antagonists that are being therapeutically being explored, but I'm not aware of them in the treatment of iron deficiency. Are you, Wayne?
I'm not aware of any agents that are available. I would refer to the hematologists for that one. But, certainly it's a novel principle, the hepcidin closing the ferroportin channel, and its role in cases of iron overload, like with hemochromatosis. Certainly it's a novel thing that I think we're going to have a light bulb moment one day where we'd say, but why didn't we think of this sooner, to upregulate the ferroportin channel or downregulate the ferroportin channel where in cases of iron overload. So I must say I look forward to hepcidin analogs, either antagonists or antagonists that would help us. But I agree, I'm not aware of anything on the market that can address hepcidin at the moment.
Yeah, pity our guru, Vernon Lowe, is not on today, but he does excuse himself. Any comments on that?
I see Professor Kutsia is with us.
Oh, sorry, Marius. Yeah, tell us.
Yeah, no, they are somewhat used in renal dialysis, but that's as far as they've got at the moment. The replacement of iron, treatment of iron deficiency in that setting, but not as far as I know anywhere else at the moment.
Thank you. And a comment from Christian Sutton. Hello, Christian, and thank you. Yes, I mean, the whole issue is we face these problems on a daily basis due to bleeding, and we often use iron therapy because of the lack of blood donors. And that's the whole point of patient blood management, is trying to train and teach people and physicians to replace blood with iron, blood loss with iron, or blood with iron rather than with blood. And when you look at the therapeutic outcomes of patients that receive blood transfusions in many settings, the outcomes are really much worse than if they did not receive them. So yes, I mean, the point is that we're trying to train ourselves and others in using both enteral and parental iron replacement therapy as the first port of call before, reaching for blood donation and blood transfusions. Any other questions? Wayne, any other comments?
I see there's a question about the young ladies with menorrhagia, but because of iron deficiency anemia, they are still being referred for colonoscopy. I think we're clear in the guidelines that this is a group that we should not ignore. In the first place, one shouldn't assume that the menorrhagia is the cause, while it is an important cause for iron deficiency. And then what we've said in the guidelines is that in this group, with menorrhagia as the cause, you would entertain upper endoscopy and iron replacement therapy in them. I think in the iron deficient patient, at least to do the upper endoscopy in this group would be valuable. And then in those with normal upper endoscopy, and those who do not respond to oral iron and addressing of their menorrhagia, and then in those with the family history of some other clue to suggest gastrointestinal malignancy, particularly lower gastrointestinal malignancy, those are the ones that should then have the colonoscopy. And the guidelines are quite clear in that group.
Yeah, I mean,
any further comments?
Yeah, just because you're a woman with menorrhagia doesn't mean you're not going to develop colon cancer. I mean, two conditions are quite common, and you're going to have an overlap. But also one of the issues clinically is not to follow-up is very important. I mean, you can't do everything in everyone at the first visit. And it also depends on your demographic. I mean, the approach to a young lady who has menorrhagia is going to be very different to the approach with an elderly patient who has iron deficiency anemia. But the important thing is perhaps to do an initial assessment, but then follow up. And for example, if you do replace your iron, follow up and monitor the rate of deterioration thereafter or the rate of stability. If the irons stabilize and they're not a problem, then you can sit tight. But if you start losing iron thereafter, you've got to readdress and repeat even endoscopies that you've done. So yes, we've made the point in the guidelines that not to assume that women with menorrhagia should not be evaluated further. But I think it's the close monitoring of these patients that sometimes gives you the clue as to where the cause lies. And there's also, iron deficiency in pregnancy. Wayne, we didn't assess this.
Yeah, so we didn't look at pregnancy. I think that's a whole different ballgame almost, if I must say. And I think, as far as I'm aware, the obstetricians and the gynecologists are busy drafting guidelines of their own with regard to this population. So we limited, obviously we'll dovetail with regards to the GI evaluation of those patients, which is an interesting thing as well. But those guidelines are under construction, as I'm aware.
Yeah, so the foundation is actually assisting because of our success with the GI guidelines, and we've got a nice formula. So we're assisting the obstetricians and the gynecologists, and those guidelines are actually in process at the moment, both obstetric and gynecological. Our hematologists. Marius, where are you? Any specific recommendations about type and dose of oral iron replacement therapy? Wayne, you first.
Yes, so I've been through. I just listed the second last part of the guidelines, a very valuable part of the document, I think, and it gives this information quite clearly. It talks about oral iron and the older formulations of ferrous ions and their role. And then it talks about the newer formulations, polymaltose and things like, or sucrosomial ions that we know are absorbed very niftily through the sucrose transporters and bypass this hepcidin inhibition, if you would say. And of course, avoid the toxicity that one sees with the ferrous formulations. So historically, and this is clear in the guidelines as well, we know that the second-day dosing of the ferrous formulations is advised because of limiting the risk of side effects in these patients and limiting the risk of this responsive hepcidin in the response to the ferrous toxicity, as well as in patients with inflammation, the upregulation of hepcidin, the inhibition of absorption, and the amplification of side effects. So the use of ferrous type ions should be limited to, alternate days and lower dose. Like in the IBD sections, we limit to 100 milligrams and not 200 milligrams. But when using sucrosomial formulations and iron polymaltose, one can give them daily, once a day, and that's shown to be adequate and slightly more effective. Well, not effective. The effectivity of both these options seems to be similar, but in terms of side effect profile and ease of use, the daily dose of sucrosomial formulations seems to be the way forward there.
You supplement with vitamin C?
Vitamin C of late is shown not to be, it's also discussed in the document, and it seems that this knee-jerk supplementation of vitamin C is not recommended. There's vitamin C in the diet. I think we can advise, a healthy diet, which is adequate in terms of the vitamin C, but the guideline doesn't suggest additional vitamin C in a tablet form. And I don't think the evidence for that is falling as the days go by. So co-administration or co-prescription of iron supplementation with vitamin C is not advised.
Marius, any comments, further comments on that?
Yes. The thing is that in experimental situations, the vitamin C improves the absorption. But I agree with Wayne that nowadays there's not much practical benefit, and you might even increase somebody with reflux's side effects by giving them large doses of vitamin C.
And the risk of kidney stones.
Yeah.
From vitamin C? Oh, I didn't know that. Okay, good. Any other questions from anyone? Unmute and let us know your thoughts.
Professor Shelley.
Hi, Wayne. Congratulations. I think you've done a phenomenal amount of work, and the guideline really reads beautifully. So congratulations to you. And also, Chris, thank you for the support of the Gastro Foundation in getting this together. I thoroughly enjoyed your presentation, by the way. I'm asking about maybe not vitamin C in the form of tablets, but what about a glass of orange juice with the iron oral formulation?
Yeah, so that's what's suggested, as I've alluded to. So the dietary stores of vitamin C. So as you say, a glass of orange juice has sufficient formulations. I always, joke with the students about chilies. There's more vitamin C in a little green chili than in an orange. So those of you who have a taste for the spicier foods, so don't ignore your chilies. And then raisins. And so there's adequate, very nice tasting foods that can supplement vitamin C. So yeah, I agree with the glass of orange juice ever so often in those that are iron deficient. There's another point, the vitamin C, as far as I'm aware, in the Free State, has been taken off the EDL. So you cannot give a vitamin C tablet to a patient in the Free State. So, it's not available to us anyway.
For any reason.
for any reason. You can use intravenous vitamin C. And I think that has its role in the ICU and that. But yeah, that versus the pharmacy, the private pharmacy shelves full of vitamin C tablets, it's definitely a difference in the state here.
So Masheka, hello. So tell us about H. pylori and iron deficiency. So we have a young female who's not really losing much iron from menstrual loss, and you do a gastroscopy and find H. pylori. Are you going to be happy that H. pylori is the cause of iron deficiency?
Hi, Chris, thank you.
And also, how does H. pylori infection give rise to iron deficiency?
So in terms of your first question, if you have any patient with H. pylori who doesn't have anemia, obviously you will treat it. The reason to test for H. pylori is in unexplained iron deficiency. So when you've excluded extraintestinal causes and in the relevant situation, you've done the GI investigations and have not been able to find the cause, have obviously excluded nutritional factors, then I think it's reasonable to then look for H. pylori, and if you find it, to absolutely treat it, and as Wayne said, to confirm eradication. I mean, H. pylori is so prevalent that I think we wouldn't be able to treat every individual in Sub-Saharan Africa with H. pylori, with the prevalence rate of 80, 85%, even 90% in some situations. So yeah, in the context of unexplained iron deficiency, having done, due investigations, then I think, yes, it's certainly worth. And of course, then in that context, you also need to exclude B12 and folate deficiency as well, because the mechanism is the same. So how H. pylori causes iron deficiency is that obviously if it causes atrophic corpal gastritis, then you're not secreting acid, and you do need acid to convert it to the absorbable form. But also H. pylori competes with the gastric microbiome for iron, for its own survival. So if you have it there, then it will, and as we know, it's a very competent organism in the stomach, much better than any other microorganism to survive the gastric acid. So it will win all the time. And then there's other mechanisms, Chris. But yes, amongst all the extraintestinal sort of associations, iron deficiency is established, as well as ITP.
Thank you. Excellent.
Thank you.
Thanks, Masheka. Excellent.
Thank you very much, Masheka.
So there are a couple of other questions. Precautions before drawing blood for iron studies. Is there a diurnal rhythm?
So we discussed this recently at one of the sort of the Iron Academy, and I think the idea, I remember we discussed with Professor Lowe, and we were clear that this should be done in the morning. So morning fasting. So after eating, you can get falsely high levels of ferritin and also falsely higher transferrin saturations postprandially. So an iron study test should be done for fasting in a patient. I think that's the precaution that I'd put forward.
And then the consumption of tea and coffee, tannins, does it affect the absorption of iron?
So the tannins do, and then importantly, so coffee, tea, rooibos is one of them. So you do get tannins there as well. So it's not the caffeine as such. And then importantly, the phytates. So tying in with the dietary supplementation, spinach, for example, the old Popeye, idea of eating lots of spinach. Spinach has mountains of phytates, and the fibers, the white fibers in the leaves, also inhibit iron absorption. So one should be very cautious about these dietary substances that can inhibit. And one should limit your tea intake. The guide that last time I read was about not more than 2 cups a day.
Okay, and then I think final question, guidance on a patient with iron deficiency who has received a blood transfusion.
So we've looked at this as well, and the idea is that a blood transfusion, while patients who are getting chronic blood transfusions, those with myelofibrosis, for example, they will all, on repeated blood transfusions, they run the risk of being iron overloaded. But a single blood transfusion, while it is laden with iron, is not adequate to say that that is supporting iron replacement. I think the emphasis here is that iron should be replaced in a patient with iron deficiency, and the blood transfusion shouldn't be almost falsely assuring as a supplement for iron in those patients. It shouldn't be counted into the iron on the Ganzoni formula, if I can put it that way.
Excellent. Well, I really enjoyed that, and I can't tell you what a privilege it is for me. I know the foundation puts all the effort in and funds these sessions, but what a privilege it is every Wednesday to be in the company of such erudite intellectuals. Well, Wayne, you are now the Tsar, iron deficiency czar of the continent. Thank you very much for such an excellent presentation. Thank you very much to the audience for such wonderful questions.
Thank you.
And thank you, Wayne, for just knocking them off. Like you were playing
Thank you very much, Prof. And thanks to you for the initial concept again. And yeah, and the guidance along the way. I cannot overemphasize my appreciation to you and the Gastro Foundation.
And really good luck with the final acceptance in the South African Medical Journal. So it remains for me to thank Wayne and thank iEcho India and our team here, Karen Fenton and Cheryl, who assist us every week, to the foundation, the sponsors. And remember that all these sessions are posted on the Gastro Foundation website, which you find at gastrofoundation.co.za. Please look at the website because it's got a very nice new site putting a lot of emphasis now on GASA, the Gastroenterology and Hepatology Association of Sub-Saharan Africa, which is going to become really the main focus of the foundation going forward over the next few years. So next week, we're now, we've split our endoscopy sessions because of the excitement that Vikesh Lala has exhibited coming back from Ghent with the Geeks Foundation. And really getting all the endoscopists so excited with his teaching, and he's posting on a WhatsApp interaction, interesting cases. We've split the endoscopy into upper and lower. So next week will be an endoscopy session, which will be devoted purely to lower endoscopy. So I encourage you all to attend. And I thank you very much for joining us up on this wonderful afternoon. Thank you very much, and goodbye to all of you.
Thank you. Good afternoon.
Thanks, Wayne.
Take care.